the recording of the session. So good afternoon, everyone. Thank you for joining us in our health seminar organized by the Center for Primary Health and Social Care. My name is Professor Yolanda Eraso, and I will be chairing the session today. So I would like to introduce our speaker, which is Dr. Stephen Hills, who I suppose many of you know already at London Met. And it's great to have him in our seminar this afternoon. Stephen is a reader in health and sport management at the Guildhall School of Business and Law. He has worked in different topics on health, including mental health interventions, for example, one that uses boxing training as a resource to alleviate depression. And most recently, Stephen and I have worked together about the COVID pandemic, analysing behavioural adherence to social distancing and self-isolation measures in North London communities. This work, or part of this work, has led Stephen to partner with UNICEF on the evidence of other behavioural responses to government measures, and how the public have complied with these measures worldwide, including mask wearing, social distancing, and vaccine hesitancy. In today's seminar, he will be presenting findings from a rapid evidence assessment of factors associated with COVID vaccine hesitancy, addressing issues such as who is more likely to be vaccine hesitant, and equally important, what are the main reasons for being hesitant. So he will also discuss some recommendations to assist practitioners in tackling this topical public health issue. After the presentation, we will have time for questions and answers, but you're welcome to use the chat box as we go along, so we can get back to those questions at time for discussion. So Stephen, when you are ready, we can start. Thank you.
Thank you very much, Yolanda, and that was a nice lengthy introduction to give me time to get my breath back after sprinting from Benwell Road to the main tower. So I appreciate that. So yeah, guys, just to give you a bit of a background in terms of how this project came about. So as Yolanda was mentioning, the two of us did some initial research looking at social distancing and factors associated with compliance with social distancing measures. And we published our first study in this area in BMC Public Health Journal, and UNICEF were looking for a partner to undertake this rapid evidence assessment. And on the basis of this publication, they reached out to me, and I formed a local team with other colleagues at London Metropolitan University, who some of you may know. So Justin Webb and Anna Baker came in on the project, and we put together a bid that was successful. And I'm just presenting one element of the project today, but it's actually part of a broader piece of work. So Justin led on looking at compliance with mask wearing, and Anna Baker looked at compliance with social distancing measures, again within the overarching framework of the rapid evidence assessment. So this is just one aspect of the work that we've undertaken. That's focusing on vaccine hesitancy, which was the area that I led on for the project. So first thing, just for this particular component of the project, just to say what the research question was. So it was, what factors are associated with COVID-19 vaccine hesitancy, and in what contexts? So this was undertaken by via a rapid evidence assessment, and to undertake this work, we first wrote a research protocol. So those of you who are familiar with systematic reviews and rapid evidence assessments will know that this is an empirical research that we're conducting. We were looking at the existing evidence that was available for our research questions, and we established a research protocol to address this. So first of all, we wanted to have a very clear exclusion and exclusion criteria. So we limited our work to just journal articles. I mean, we were quite surprised after we'd bid for the work and started to look at the evidence that was there, and it was a lot. We thought that maybe it wouldn't be so much because it was a relatively new phenomenon, and back in the summer when we started working on this, we knew there would be a lot of researchers were working on these topics, but we didn't fully appreciate the extent of the work. So we made, with this in mind, we were very specific with our inclusion and exclusion criteria. So we only included in our review journal articles. So anything that was a preprint or not a journal article was excluded. We only considered articles written in English. We had a cutoff point of 30th of June when we started this work. As part of the broader work, we were looking at the interventions of the vaccine program, social or physical distancing, self-isolation, or test and trace programs, mask wearing and hand washing. But we weren't going, for my particular vaccine hesitancy that I'm focusing on today, it didn't include any research around the efficacy of the vaccines that I'm sure Una and colleagues would be, and Gary would both be very familiar with. It was very much around behaviours and whether the factors that were associated with somebody either being willing to receive the vaccine or being hesitant towards the vaccine. We were very clear that this was only to be, we were only looking at evidence within the context of COVID-19. We weren't considering other viruses such as SARS, Ebola, swine flu, or anything that wasn't COVID-19. And we wanted to be clear that we were very much interested in terms of studies that addressed our research questions. So we were investigating factors associated with compliance, adherence, uptake, or non-compliance, non-adherence, or hesitancy. So we tried to define those in various ways, and we reflected that within our the keyword and search strings that we used. But we also included efficacy of campaigns or interventions to increase vaccine uptake or non-pharmaceutical intervention compliance, but we got very few of these in our return. It was very much observational research looking at factors associated with vaccine hesitancy and the MPIs. We only looked at studies that were considering either a general population for a given territory, or if there were specific populations defined by demographic factors of ethnicity, gender, or age. We included those as well, but there was a lot of studies that had specific populations defined by factors other than demographic factors. In particular, there was seemed to be a lot of research that looked at hospital populations and staff at hospitals. We felt that was too specific a population and it would just muddy the water. So we excluded those studies. We were only interested in empirical research. It didn't have to be quantitative, it could equally be qualitative, but the vast majority of research were cross-sectional survey designs, mainly using regression models to look at the associations between factors or designs. We didn't include anything that was theoretical or conceptual, or lacking explanation of methodology, or that was again a secondary literature review or a systematic review or rapid evidence assessment, because that would involve double counting. So they were excluded. So as you can see from this inclusion and exclusion criteria, we did try to be very focused because of the amount of evidence that was out there. So we did want to make it a manageable project, and that's reflective in the inclusion and exclusion criteria we applied. So with our research protocol, once we'd established that, we then defined our keywords and search strings, and we tested these out with various searches. We focused on 3 databases for our search, so PubMed Central, Web of Science, and then finally Google Scholar, which enabled us just to pick up a few more studies that weren't in PubMed Central or Web of Science, but the majority were there in PubMed Central and Web of Science. We then went through a screening process, which first of all involved title screening, then abstract screening, and a full text screening. At each stage, we were knocking studies out. And then we undertook a quality appraisal, so studies that weren't of a sufficient quality in our where we had a criteria for what reflected quality, but it primarily revolved around, did they use an appropriate methodology to study what they intended to. So that because we only wanted journal articles, that all studies will have had to have gone through some element of peer review. So there wasn't too many studies that got knocked out at the quality appraisal. It was primarily studies were excluded because they were too specific a population. And the data analysis and synthesis, it looked at the associations between factors and vaccine hesitancy. It then, because the question was about in what context, we also analyze the data in terms of were there specific patterns according to region, were there specific patterns according to cultural groups, and were there specific patterns according to income of a given territory. So this extra layer of analysis, beyond simply looking at what the associations were between factors and vaccine hesitancy, allowed us to consider the context of the evidence, although what we tended to find was that the majority of the research, certainly within the area of vaccine hesitancy, was coming from the UK and coming from the United States. So the theoretical framework that we used, I'm sure most of you will be familiar with this, is the Combi model from Mishi. And this proposes that there are 3 components which play a pivotal role in producing behavior and which therefore can be modified to change behavior. What we actually found was that maybe the Combi wasn't the best theoretical framework for grouping the factors that we found to be associated with vaccine hesitancy, but it did have the advantage of being connected to the behavior change wheel, which helped us to inform policy implications. And we're in the process now of finishing up the write-up for this rapid evidence assessment and moving on to a document which details the policy implications. So the behavior change wheel and the different elements of that are the framework that we're using for that. So although the Combi model wasn't necessarily the best, and there was maybe some theoretical frameworks that would have better fit the data and the evidence, the main thing that UNICEF were interested with this research was informing their stakeholders. So we really need to make sure that what we were doing was going to be impactful and was going to have a practical from the perspective of the stakeholders of UNICEF. And we also, as part of making sure that what we were doing was going to be practical and impactful, we also made use of the APPEASE criteria to inform the feasibility of interventions and policies in different contexts. And what you'll see as I get through the presentation is that there really wasn't too many universal patterns in terms of factors that are associated with vaccine hesitancy, and we see in different contexts factors are significant, factors are not significant, or factors may even operate in the opposite direction. So what we've advocated is that we weren't really, from this rapid evidence assessment, going to be in a position to make universal sweeping recommendations. So with the next brief that we're working on, we're actually using the behavior change wheel, and we're providing a guide as to how different states can come up with their own interventions, and we're providing them with a model through which to do that, and that brings into consideration the APEAS criteria of acceptability, practicability, effectiveness, affordability, side effects, and equity. So this is in the second brief that we're currently working on for UNICEF. So moving on to the findings of the REA for factors associated with vaccine hesitancy. So in terms of the different studies that considered the factors that were predictive of vaccine hesitancy, in total there were 54 studies, and these covered all regions, but there were relatively few in Africa, South America, and Oceania. The majority of studies were in a European context or North American context, or an Asian context, but when we're talking about evidence from individual countries, it was primarily UK and the US. Half of the studies in the context of countries were in that Anglo-cultural group, so this reflects a lot of evidence coming from the UK and the US, and the vast majority of studies were on high-income countries. So we can see that 47 of the countries were in the context of high-income countries. So 54 studies, but there is a need for looking at lower income studies and moving outside the UK and the US and Europe and Asia to look at other areas, especially considering that the areas that haven't got any evidence are some of the areas that suffer the most from vaccine hesitancy. So despite there being a lot of research around vaccine hesitancy, there's still a need for more in other contexts. So looking at the different factors, so first of all, thinking about demographics. So as I was mentioning, you can see here on the table on the right how we addressed this idea of in what context. So first of all, it was a matter of thinking about, okay, how many studies found that a given factor was predictive. So we looked at this at the highest level, and of the 48 studies that considered the relationship between age and vaccine hesitancy, 34 of these, or 71%, said that age was statistically significantly associated with vaccine hesitancy. However, so that's quite conclusive. 71% of studies say that age is predictive of vaccine hesitancy. But when we actually dive deeper and look at the relationship between factors and vaccine hesitancy in the direction of relationships, we can see that it's less conclusive that as age increases, vaccine hesitancy decreases. So that was what we would hypothesize, right? That the younger age groups are more vaccine hesitant. Well, even though 71% of studies found that age was associated, only 56% of studies found that as age increases, vaccine hesitancy decreases. So there was a few studies that found that as age increases, vaccine hesitancy increases, which is very counterintuitive, but still some studies that found that, but also some that used measured age as a categorical variable rather than a discrete variable, and where we found that the relationship between age and vaccine hesitancy was non-linear. So things like the youngest age group and the oldest age group being more hesitant, or a middle age group being more hesitant, just no clear direction in terms of what was the relationship. But then quite a few studies that found that age was non-predictive. So not a completely conclusive finding there about age and vaccine hesitancy, but when we dive into the detail a bit more, and we think about the context, so we think about region, we think about cultural group, and we think about income. So when we segment the evidence by region, there was more conclusive evidence, i.e. 81% of studies, that as age increases, vaccine hesitancy decreases in European countries. So when we restrict the data to European countries, that relationship becomes stronger. And then when we segment the evidence by cultural group, there was more conclusive evidence that as age increases, vaccine hesitancy decreases in the cultural group of Germanic Europe and Nordic European countries, where in both of these different cultural groups, although Not a lot of evidence, so only 5 studies in each of those cultural groups. 100% of those studies found that as age increases, vaccine hesitancy decreases. Then when we look at gender and vaccine hesitancy, again, this was another area where most of the studies considered this factor. So 44 studies considered the relationship between gender and vaccine hesitancy. There was conclusive evidence that gender is predicted with vaccine hesitancy, just as the case with age, and conclusive evidence that females are more likely to be vaccine hesitant than males. We could see some patterns when we segmented by region. So there was some conclusive evidence that females are more likely to be vaccine hesitant than males in Europe, and that was evident in 66% of studies in Europe, and that was equally conclusive. The evidence was equally conclusive in the context of Asia, where 63% of studies found that. Then when we segment by cultural group, there was conclusive evidence, or 100% of studies, that females are more likely to be vaccine hesitant than males in Middle Eastern countries. And then you can see that there's some fairly conclusive evidence where I've highlighted the cells in orange, but the conclusive evidence is where we see a pattern, and I've highlighted that in green. So moving on to some other demographic factors. So thinking about highest level of education and vaccine hesitancy. Again, this was an area which received a lot of attention. 34 studies, 23 studies found that the highest level of education was associated with vaccine hesitancy, and 19 of those studies, or 56% of the studies, found that highest level of education was negatively associated with vaccine. So negatively associated with vaccine hesitancy. So as education increased, vaccine hesitancy decreased, and few studies found different relationships. So that was fairly conclusive. 11 studies found that the highest level of education was not associated with vaccine hesitancy. So overall, we conclude that there's substantial evidence that as highest level of education increases, vaccine hesitancy decreases, such that those with less education are more likely to be vaccine hesitant. Looking at socioeconomic status and vaccine hesitancy, so 18 studies considered the relationship between socioeconomic status and vaccine hesitancy. 13 of these studies, so 72%, found that socioeconomic status was negatively associated with vaccine hesitancy. Only 5 studies found that socioeconomic status was not associated with vaccine hesitancy. So overall, from reviewing these studies, there is quite conclusive evidence that as socioeconomic status increases, vaccine hesitancy decreases, such that those of a lower socioeconomic status are more likely to be vaccine hesitant. Then in terms of marital status, so 11 studies considered the relationship between marital status and vaccine hesitancy. 7 of these studies, so 64%, found that marital status was associated with greater vaccine hesitancy, but within those 7 studies, 5 of them found that unmarried was associated with greater vaccine hesitancy, and being married was associated with that should be lower vaccine hesitancy. Apologies, that's a typo there. 4 studies found that marital status was not associated with vaccine hesitancy. So overall, when we look at this distribution of 5, 2, and 4, we have to conclude that the evidence is rather inconclusive that being unmarried is associated with greater vaccine hesitancy. Looking at political orientation, so there were 11 studies considered the relationship between political orientation and vaccine hesitancy. 8 studies found that political orientation was associated with vaccine hesitancy. 3 studies found that it was not. So we can conclude that political orientation is associated with vaccine hesitancy. A bit looking at the evidence in a bit more detail, we see that more liberal political orientations are associated with greater vaccine uptake and more right-wing and conservative political orientations associated with vaccine hesitancy. So this was a lot of this research was conducted in the US, where more Republican voters were more likely to be vaccine hesitant than Democrat voters. Having children was another area which received quite a bit of attention. So 10 studies looked at this. 4 studies found that having children was associated with vaccine hesitancy, but very inconclusive in that 2 found that it was associated with lower vaccine hesitancy and 2 found that it was associated with greater vaccine hesitancy, and 6 studies found that it wasn't associated with vaccine hesitancy. So we have to conclude here that having children is not associated with vaccine hesitancy. Some studies considered whether somebody lived in an urban area or a rural area in the association of that factor with vaccine hesitancy. There were 8 studies that looked into this. 2 studies found that living in rural areas was associated with greater vaccine hesitancy, but also 2 studies said the same about people living in an urban area, and 4 studies found that there was no association. So again, we have to conclude that whether somebody lives in an urban or rural area is not associated with vaccine hesitancy. So that's taken us through the different demographic factors that were primarily evident in the evidence that was reviewed. Next, we're going to look at some, again, within the structure of the Combi model, we're going to look at psychological capability. So psychological capability was one element of psychological capability is knowledge, and 8 studies considered the relationship between COVID-19 and vaccine knowledge. So knowledge was measured in 2 ways, knowledge about the virus and knowledge about the vaccine, and vaccine hesitancy. So 6 studies found that knowledge was negatively associated with vaccine hesitancy, and 2 studies found that it was not associated with vaccine hesitancy. And interestingly, looking at this evidence, it was only when knowledge was self-reported rather than tested, including acceptance of conspiracy theories, was knowledge found to be not predictive of vaccine hesitancy. So on the basis of this, we can determine that there's conclusive evidence that knowledge is negatively associated with vaccine hesitancy. So as knowledge increases, vaccine hesitancy decreases, and also that those who accept conspiracy theories are more likely to be vaccine hesitant. That's not a surprising finding there. Then moving on to reflective motivations, and most of the factors that were evident in the studies that were reviewed considered reflective motivation. So first of all, perceived susceptibility to catching COVID-19 and vaccine hesitancy. 14 studies looked at this relationship, and there's some evidence, 57% of studies, that perceived susceptibility to catching COVID-19 is negatively associated with vaccine hesitancy. So as perceived susceptibility increases, vaccine hesitancy decreases, and those who perceive themselves to be less susceptible to catching COVID-19 are more likely to be vaccine hesitant. Then perceived severity of COVID-19 and vaccine hesitancy. 13 studies considered this, and there's conclusive evidence. So 85% of the studies, as we would expect, found that perceived severity of COVID is negatively associated with vaccine hesitancy. So as perceived severity of COVID-19 increases, vaccine hesitancy decreases, and those who perceive severity of COVID-19 to be lower are more likely to be vaccine hesitancy. And also, when perceived severity was defined in terms of fear in studies, the strength of this negative association increased. There were 3 areas that I grouped into a single factor. So these were perceived vaccine safety, trust in vaccine, and concern over side effects and vaccine hesitancy. So 13 studies considered the relationship between these factors and vaccine hesitancy. And there's conclusive evidence whereby there were 100% of studies that perceive vaccine hesitancy and trust in the vaccine are positively associated with vaccine hesitancy, and that concern over side effects was was also positively associated. Well, sorry, that was negatively associated with vaccine hesitancy. Sorry, a typo there. So as perceived vaccine safety and trust increases, vaccine hesitancy decreases, and as concerns with side effects increase, vaccine hesitancy increases. So the relationship that we would expect to see. Those who perceive the vaccine to be unsafe, don't trust the vaccine, and have concerns over side effects are more likely to be vaccine hesitancy. So, and in the research that looked at reasons for vaccine hesitancy. So rather than putting factors into a regression model and measure the association, where studies identified people that were vaccine hesitant and then asked them as their reason, the reasons around perceived vaccine safety, trust, and concern over side effects were the reasons that were most commonly stated in these studies. Then trust in healthcare professionals or organizations and vaccine hesitancy. There were 8 studies, and again, 100% of these found that trust in healthcare professionals or organizations was negatively associated with vaccine hesitancy. And there's conclusive evidence that trust in healthcare professionals or organizations is negatively associated with vaccine hesitancy, whereby as trust in healthcare professionals or organizations increases, vaccine hesitancy decreases. And those with low trust in healthcare professionals or organizations are more likely to be vaccine hesitant. Again, this is the direction of the relationship that we would expect. Similar findings for trust in government and vaccine hesitancy. 6 studies looked at these, and all but one of the studies found that trust in government was negatively associated with vaccine hesitance. There's conclusive evidence, therefore, that trust in government is negatively associated with vaccine hesitancy. So just to summarize these findings, so who are the most likely to be vaccine hesitant? So younger people may be more likely to be vaccine hesitant, but that wasn't evident in all contexts. A stronger finding was that females are more likely than males to be vaccine hesitancy, and those with lower levels of education may be more likely to be vaccine hesitant. Those of a lower socioeconomic status are more likely to be vaccine hesitant. That was quite conclusive, and political orientation was associated with vaccine hesitancy. And what are the main reasons for that evident in the research? So first of all, lack of knowledge and acceptance of conspiracy theories is associated with vaccine hesitancy. Lack of perceived severity and fear of COVID-19, lack of trust in the vaccine in terms of safety and its side effects, lack of trust in healthcare professionals and organizations, and lack of trust in governments. These were the 5 main reasons for vaccine hesitancy evident in the studies that we reviewed. So moving on now to policy implications. So how might we support younger members of society to receive the vaccine? So first of all, a word on and a warning about incentivization, whereby bribes should be used with caution. So UNA, stop giving out food vouchers and coffee vouchers, please, because there's no evidence currently to support effectiveness of lottery-based incentives in the United States, cash incentives of up to $100 only marginally increased, thanks Una, vaccination rates in Australia. And there's an issue here with sustainability, because if we're incentivizing people to get a vaccine now, we're starting to see evidence rather conclusively that very regular vaccines are going to be required. We're going to have to bribe people every time. It's much better that we look at ways so that they're internally rather than externally motivated. Better way to support younger people to receive the vaccine might be environmental restructuring, so presenting easy and convenient opportunities to receive a vaccine. So an example of this, that the NHS in the UK are using up pop-up vaccination sites near young people's most common work, study and leisure locations. So thanks to Una and her team, there was a pop-up vaccination site here at London Metropolitan University. And then enablement, so smoothing out the registration process for an appointment. Again, the NHS are making it easier to book and cancel appointments online. And with the walk-in pop-up centre here at London Metropolitan University, it was a very straightforward process. Just turn up and get your vaccination. Building trust in the vaccine. So the way to do this is through good communication. So transparent communication about vaccine trials between vaccine manufacturers, health officials, and communities. When we were doing the various workshops around the vaccine, what time would have that been? What, maybe 6 months ago we were doing those, Una, around that time. And I was responsible for looking at the vaccine trial data. It was very difficult because what you would see is that that you would get press releases which talked about high-level aggregate back in November. It was, that's right. So a year ago, more than a year ago. When I was looking at this data, it was high-level aggregate data, and you couldn't actually go in, very difficult to go in and look at the granular data and really analyze it and have trust in it. There should be consistent message on risks in pregnancy and when breastfeeding. There's certainly examples of people, of pregnant ladies turning up for vaccines and being turned away because there's inconsistent messages and inconsistent understanding. Providing comparable data on blood clot risk from vaccine versus COVID-19 itself, and even the other things that can that there's risk from blood clots, such as birth control pills. Releasing aggregate data from the aggregate from trials rather than just headline efficacy rates. And this is a headline piece of data that was released by Public Health England, which was that in the first half of 2021, only 1 in every 200 deaths from COVID-19 was of somebody that was double vaccinated. So even though people might perceive that they're not that they're not vulnerable and that they might not particularly trust the vaccine, this is quite compelling evidence in terms of thinking about whether or not the vaccine works. You know, that's very, very conclusive evidence that the vaccines are working. It's very difficult to refute those kind of numbers and a ratio of 1 in every 200 deaths. Overcoming lack of trust in healthcare and government. So in terms of how this can be done, it can be done via modeling. So understanding community hierarchies and local patterns of trust. So to deliver messages via age appropriate, relevant and trusted people known to each target group. So for example, adverts featuring nurses who had rejected the jab but then changed their mind were shown to care home workers, producing a 93% acceptance rate. Compared to the 80% typically found in major UK centres. Or an example from the Democratic Republic of Congo during the Ebola outbreak was that local authorities were more trusted than national levels of government. So ensuring that messages are going via these trusted sources. Improving knowledge by challenging conspiracy theories. Again, this is something to be achieved via communication. So anti-vax conspiracy theories revolve around themes of power, personal freedom, agency, citizen against state, and loss of traditional lifestyle. And these are now actually being extended to the climate change challenge. So, and mega media corporations labeling pseudoscience as misleading may only support the beliefs of conspiracy theories, and that themes of power, personal freedom, agency, citizen against state, and loss of traditional lifestyle should be engaged with at a broader level beyond the context of COVID-19. So it's only when we address these broader themes that we'll have a better chance of taking on the anti-vax conspiracy theorists. Overcoming lack of perceived severity and susceptibility. So this can be tackled via coercion, so communication of risks for groups who do not perceive themselves to be vulnerable or susceptible to COVID-19. For example, presenting occupancy rates in hospitals for different age groups, and communication in terms of using text-based reminders that create ownership. For example, a COVID-19 vaccine has been reserved for you, or sending details of pre-booked appointments. As an example of this working in a study, text-based reminders increased appointments by 84% and vaccination rates by 26% in a UK experiment undertaken by Diatel 2021. And then just to think a bit about the difference between vaccine resistance and vaccine hesitancy, because several studies made this distinction. It's not necessarily a binary variable as as most research has treated it. So distinguishing between tackling hesitancy and resistance, and there is an argument to say that when people are resistant, don't waste resources on trying to change their mind, because you won't be able to, and to focus resources on those that are hesitant. In terms of regulation, nudges are going to be ineffective for anti-vaxxers, but mandating to receive the vaccine may have the perverse effect of causing the vaccine hesitant to become vaccine resistant, but is necessary for professions in contact with the vulnerable, such as care homes and frontline health workers. So it really mandating, I think, is more effective when it's a behavior such as wearing masks. I mean, certainly since mask wearing has been mandated on the underground, I think anybody that's traveling by tube to Holloway Road, certainly what I've noticed is now the vast majority of people are wearing masks, whereas that wasn't the case before mask wearing was mandated. However, mandating it might not work so much with vaccine hesitancy, and I think there's stronger feeling around vaccine hesitancy than there is around wearing a mask. So restrictions can also work. So rather than mandating something, less severe is restricting unvaccinated members of society's contact with vaccinated members via vaccine passports and selective lockdowns. An example of this is that the unvaccinated have been were placed initially in lockdown in Austria, so to limit their contact with the vaccinated, and immunization records for children are required for them to be enrolled in schools in France. We could also make use of fiscal measures, so financially incentivizing individuals to receive the vaccine. So tax rebates for immunization in Australia, or even a kilogram of lentils in rural India have been found to increase immunization. But you've got to think about the dead weight cost to incentivizing those who are not vaccine hesitant. So more targeted financial incentives are recommended. For example, Singapore has said that those who remain unvaccinated by choice will have to pay for their own medical bills from December, which I think is quite a good, quite a clever way of using fiscal measures in a more targeted way without a dead weight cost. And that's the end of my presentation. So we've still got a few minutes for any comments or questions.
Okay, thank you very much, Stephen.
Thank you everyone for attending. You're welcome.
We're now opening, the floor for questions. You can either use your raise your hand and use your mic, or you can type your questions in the chat box. Yes, Gary?
Yeah, hello everyone. Thanks, Stephen. That was really nice. I wonder, I may have missed it. I wonder if you found any studies that looked at vaccine hesitancy and whether or not people had been infected previously with SARS-CoV-2 or not, and if so, if that had changed their mind at all. Because you read these stories sometimes in the news, in the media, that a person who was a non-believer, if you like, in vaccines then got infected and then was saying, well, I should have done that previously.
Yes, Gary, there has been a few studies on that, and that is an aspect of the REA that I haven't yet completed. So I'm trying to if I just quickly pull up my my notes on that. I don't know if I've actually gone into the detail of concluding that. So there certainly has been some studies on that. Let me just quickly grab those findings.
At the same time, that might also, someone that may have been previously infected might think to themselves, well, I no longer need the vaccine as well. So it could be a difficult one to determine.
Yeah, so there's been a total of 1, 2, 3, 4, 5, 6, 7, 8, 9. So we had 10 studies on that, and it's quite mixed findings. So like you say, it can have it can go in both ways. So there was a few of the studies out of those 10 that found that if somebody was infected, they were more likely to receive the vaccine, and some that found that if somebody had been previously effective, they were more likely to be hesitant because they felt that they'd got some immunity from that. And then there was, but the majority of the studies there found that actually there was no association between an infection and being vaccine hesitant. So when I finish that section of the write-up, Gary, I'll give you a preview of it before we publish that report, so I can give you a more definitive answer to that question.
Yeah, that's great. Thanks very much, Stephen.
No problem, Gary.
I think Una.
Hiya. I think on that topic, maybe the people that might be converted more by experience of infection might be relatives of people who were either severely infected or died, or relatives or friends of people. That might, because I think, like Gary said, once you're once a person who's like a non-believer is infected, they might then go on to think that they're fine and it was fine, it didn't kill them, so it proved, you know, their point of view. But people who are, as you know, in the environment where they've seen somebody really sick or perhaps even die, they might be more likely to be converted, if we're interested in converting people in that way. And if that's true, then that means that you know, advertisements could target those people, and also I've completely lost my train of thread now, but anyway, yeah, so oh no, I know, and that it ties in with the really nice message that education changes people's minds, that the more educated somebody is, the more likely they are to accept a vaccine, which is really great, because obviously we're in the business of educating, and it means that all the efforts that we've made doing talks to the public and our community are actually worthwhile.
Yeah, I think how that could operate within studies would be, instead of actually measuring whether or not somebody's had a previous infection, it's whether they've been hospitalized or whether they know somebody that's been hospitalized or died from COVID. Because with that as a factor, I think there's a clearer relationship, isn't there, that as if that is present, if somebody knows or is related to somebody who's been hospitalized or died from COVID, then you would expect that to decrease their vaccine hesitancy. Whereas the infection could go either way. If somebody's had a mild infection, they'll think, oh, COVID is nothing, I don't need a vaccine. But if somebody's had a severe infection, it then connects to perceived severity of COVID, and which was very strongly associated with vaccine hesitancy.
And can I add on that note, we have someone in the chat from, I think it's a vaccination coordinator group. I think the colleagues are from Canada, if I'm not wrong. Says that anecdotally, we are finding persons asking for vaccine post-COVID infection after surviving the emergency state, almost all of them. Intensive unit, right? Almost all of them are asking after surviving for a vaccine. So I think it's related to what you just said, Stephen, that if they have the infection, not a mild infection, but requiring hospitalization, are likely probably to have the vaccine afterwards.
Yeah, I think that makes sense. So when it's a severe infection, then that's much more likely to have a positive association and with vaccine uptake, and encourage people to receive the vaccine.
Can I have a comment and think for your thought? I think one thing is important that your paper is bringing is that there's a lot of the context matters, isn't it? You say it at the beginning, and you say that you will be sort of developing a specific or more targeted report for different areas, isn't it? Just bringing you a bit to the UK, and I know that your study stopped in June, but just as a reflection, in regards to younger groups, which has been identified in many places as being one of the more hesitant group in terms of age. And I was thinking that the UK government, for example, chose to remove all restriction, as you know, in the 19th of July that we went into Freedom Day, before everyone in the country had been offered the jab. That means that the message that was sent is that it's not important for young people to be vaccinated. So it is unsurprising to see lower uptake rates in these groups, in younger age groups here. I suppose the trust in government factor here, so sending people the wrong message, in fact, will turn probably that association the other way around. So probably if you trust in government here, the more you trust in government, if you are a younger person, the more vaccine hesitant you become. You see, in terms of the context, because as I said, I mean, the idea or the message, and this is linked to trust in government, was that it was safe to be out and about without a vaccine at the time. Stephen, I don't know if you would like to add. I think that Stephen is reconnecting at the moment. I think we lost Stephen. Okay, so let's wait for a second for him to reconnect.
Sorry about that, Yolanda.
Okay.
I missed the end of your comment. I got disconnected, but it's reconnected.
Yes, just to cut it short, I mean, the government here, when we went on Freedom Day in July, they knew that many younger people were not vaccinated. So I think that in our case will be that if you trust in government, you probably are going to be vaccine hesitant if you're a younger group, because the government have told everyone that it was not at risk, to be on Freedom Day, that no young people was at risk, and they were unvaccinated at the time. I mean, this is the important thing. So they were unvaccinated. So I was just saying that it depends on the context of this thing, and also older people at the moment. Westminster has the highest rate in older people of not being vaccinated. So, and something similarly happening with the booster vaccination. Lowest rates are in London as well, in certain areas, Westminster, for example. I was just checking the data. So you have that disparities as well in older groups not taking vaccine, but that is interesting to consider, isn't it?
Yeah, and I guess it depends on what message you're listening to, because although there was obviously this Freedom Day message, the government has been consistent since then that the best form of protection is the vaccine, and that if we want to avoid restrictions, that the way to do that is via the vaccine. So I guess trust in government again is one of those things that could work either way in the context of the UK.
Mm-hmm. Let me check. Is there any other questions? Diane says, a new NPR study in the US is showing that political orientation has an effect on vaccine uptake versus deaths. And she's put in the journal. Thanks, Diane. I don't know if you can see the chat box, Stephen. I mean, do you want to comment on that?
Yeah, I mean, that's certainly what we saw as well, that this is very much reflective of some of the studies that I looked at. The pro-Trump counties now have a higher death rate from COVID than counties that voted for Joe Biden. So this is really interesting, Diane, because it's taking it a step further. What I saw in the studies that I reviewed, which was that if Republicans were more likely to be vaccine hesitant, and we're now actually seeing that, yes, in a very Darwin, now we're seeing that is leading to higher death rates, and that's what you would expect to see. Greater vaccine hesitancy is going to lead to greater deaths.
Yeah. Okay. Okay. So are all you ready for new measures coming our way? And the government, speaking about trust, is a big concern apparently that people are not going to follow the rules for Christmas, the Plan B. So there will be surely more to analyze, isn't it? I mean, continue seeing all these things that you have mentioned in terms of age and the relative, streets, Christmas party, and down the street, So how damaging can be, isn't it? Well, just to illustrate our colleagues that are outside the UK, I mean, it's just some Christmas parties that took place at the time where we were under rules and the social distancing rules, and that party took place in the heart of the government.
Allegedly.
Yes, and quite strongly, allegedly, apparently, by the look of things. So I think that the trust,
didn't it?
Yeah, trust in government is just so relevant and so important, isn't it, for people to follow these measures, that many of them are law and many of them are just measures or guidelines, is the proper term, advice to follow. And so and the same happened to vaccines, because we don't have an obligation to have vaccinations at the moment. They have refused to have a COVID passport so far, as opposed to other countries. So there's a lot of things that to continue, I suppose, with this analysis, and also with this virus that is never ending. I don't know, Stephen, you have the wrap up, if you like. To say something, just to finish. I suppose that we don't have any more comments. If you like to say something.
Well, just to thank you to everyone that attended, and we're in the process of writing up this research, and we're aiming, I think, the period of over the Christmas break, we should be finishing up the report and publishing it soon after. So I'll be sure to share it with everyone. So thanks very much for attending, and thanks for your comments and questions.
Thank you, Stephen. The recording will be available in the Facebook page of the centre, where you register. You will see a link there to the Facebook page if you like to come back to this, or get in touch with us if you would like, probably some data or the report from Stephen as well. And thank you so much, Stephen, for joining us today. Thank you.
Thank you for the invitation, Yolanda, and thank you for sharing.
Goodbye, everybody.
Bye, everyone. Thank you.
Thank you.
Stephen, could I just catch you for a second?
Sure, yes.
So I've stuck a template on Google Docs,
yep.
and it very much needs to